Thank you very much, everyone, and welcome to our masterclass where we're going to talk about the why and exploring the new asthma guidelines and what they mean for patients. And this is part of a suite of masterclass presentations, and I am delighted to say that this is in partnership with Asthma+Lung UK. I will introduce myself in a moment, and then after I have finished, I will hand over to Laura Williamson, who will take the opportunity to introduce herself and take you through the wonderful sterling work that has been done at Asthma+Lung UK. So a wee bit about education for health today. Who are we? We have had a lot of experience, nearly 40 years experience, working with healthcare professionals to drive improvements in patient outcomes. We're a dynamic UK-based healthcare charity, providing healthcare professionals with the knowledge and know-how along lots of different long-term conditions. And Education for Health regularly engages with over 27,000 healthcare professionals right across the UK, and the insights from those interactions have helped to shape what we discuss today. The other thing to add is that Education for Health is supported by experts who are working in the workplace. We have a team of clinical experts from different healthcare professionals, backgrounds, and a board of trustees who are experts in their respected fields, and esteemed professors and consultants who sit on our clinical practice advisory board and committee. Associates from across the UK are supporting the development of all of our courses. So today we're going to be focusing on the why. Why do we need to make these changes? So at this opportunity, I'd like to hand you over to Laura, who will take you through the work done by Asthma+Lung UK. Thank you, Laura.
Thank you so much, Julie. Hi everyone. My name is Laura Williamson. I'm a policy manager at Asthma+Lung UK. And for those of you who might not know our charity, so we are the nation's lung health charity, and we're fighting for everyone with a lung condition, whatever that lung condition might be. But of course, we do a lot of work with our asthma patients. Our North Star goal as a charity is to reduce deaths and ill health caused by lung conditions by 20% by the year 2027. And changes in the healthcare and policy landscape, like these new asthma guidelines, are a really, really important way of us achieving that. Some of the key things that we do as a charity are that we campaign for the best possible care. We prevent lung conditions wherever we can, and we do that with a focus on reducing air quality and tackling tobacco and vaping. We provide support and information, so we have hundreds of pages of health advice on our website and a helpline that is open for people with lung conditions, but also for clinicians if they have questions on how best to care for their respiratory patients as well. And we drive life-changing research and innovation through funding and support of researchers. If you can take me to my next slide, please, Julie. So I just wanted to sort of set the scene, the why, why this is important, why we should in this room care about asthma and about lung conditions in particular. And I think the first stat that's really important and is a key driver for us is that respiratory conditions are England's third biggest killer. We hear about cancer and cardiovascular disease and diabetes and obesity and all of these other conditions all the time. They're always in the headlines. But actually, the stats don't necessarily back that up as why we should be caring about those in comparison to lung conditions. And yeah, we are the third biggest killer. It is a massive problem, but we are continuously under prioritized. And that's something that we are really keen to change, both at a policy and political level, but also with clinicians, and making sure that you guys really understand the importance of supporting our patients with asthma. If I can have the next slide, please. So this is a slightly busy slide, so do forgive that, but I think it's a really important one because it actually shows that in the United Kingdom we have the worst death rate for lung conditions in Europe. And I think that often takes a lot of people by surprise. We don't have the coldest weather, we don't have the the worst economic climate, but we do have the worst death rate, and that's really indicative of the care and the health system that patients are existing within, and the changes that need to happen to really improve that. If I could have my next slide. This is something that is a major driver of our work at Asthma+Lung UK at the moment, and that is that respiratory conditions have the biggest mortality gap between rich and poor than any other major condition. So the top three that have the biggest mortality gap for those that are rich and those that are poor are COPD, lung cancer, and asthma. And for us, that's, it's so important and is really indicative of how we need to be making sure that we're reaching those lesser heard from populations, and those people that are really struggling to access care, and survive in what is, quite frankly, quite a tough world out there at the moment, and respiratory patients seem to be being hit the hardest by that, and it's certainly something that we need to all be aware of and work to change. My next slide, please. And this one, I don't think comes as a surprise to many people, that respiratory conditions are the leading driver of hospital admissions and winter NHS pressures. We all know that wards get chock-a-block full of respiratory patients in the winter, and that winter can trigger pretty much all lung conditions. So it's definitely a time of year that, the sun has come out now. We might be on the other side of practically, but it's a recurrent theme every winter, and it really requires that year-round proactive care of our patients to prevent this from happening in every winter from now on onwards. I think also what this graph is showing is that difference between the most and least deprived. So the difference in hospital admissions for those that are the most deprived are 2.3 times higher than those that are the least deprived. So again, it's going back to that point that it's the same people that are being affected by all of these different things, and that we really need to be working to protect and to care for. My next slide, please. And then this is my final bit of data before I will talk in a slightly more positive way, and that is that respiratory conditions are the second leading contributor to NHS bed days, and for us this is really important as a tool to influence change, because when thinking about how to reform the NHS and where those levers for change are to really improve the system and the care that patients are receiving, then reducing respiratory will be a really great way of reducing those pressures on the NHS. And my next slide. So obviously we are a patient-facing charity, and we hear from patients day in, day out on our helpline, and I think it's really important that I bring some of those perspectives to you here on this webinar. So the first quote I have is from a lady that is in her 60s, and she lives in London, and she says to us that lung conditions are not taken at all seriously by GPs except in ruling out cancer. Then it's inhalers with very variable amounts of steroid and antidepressants if you say you're worried because you're struggling to breathe. Lung problems are often devastating and affect every aspect of life, including the ability to work. And there are a huge number of people affected, especially since COVID. It's hopeless, really. And I think that quote is something that I often talk about and read out to people. I think that it really captures how patients are feeling up and down the country, and this sense of hopelessness, which is really sad, but also it's really important that we're aware of that so that we can change it. The second quote is from a lady with asthma in Wales, who says that she received a text from her GP saying they were changing her daily medication without having seen her or had a recent review. This was alarming, and in questioning them, they said it was for financial reasons. This is a serious life-threatening condition. How can this be considered without knowing how the individuals might react to this new medication? And I think this is particularly pertinent when we're thinking about the new asthma guidelines. There are new treatment regimes within the guidelines, and patients might be being switched, and it's really important that patients, one, understand why they're being switched, two, that it's not done purely for financial reasons, and that it's actually done as a package of good care for these patients so that they receive their inhaler technique check and they know how to use their medication and they understand how to care for themselves. And that's something that everyone on this webinar can make sure is happening for our asthma patients. And then my final quote is just for someone who is a carer for someone with interstitial lung disease. And she says that her mother had recently died due to her lung condition, and she was in the ambulance for 17 hours, and they sent her home a few hours later. And an hour after the paramedics left, she died right in front of us. She died waiting for help, for care, for treatment. And I believe that because she was elderly, nobody cared. I think it's really important that we hear these really quite sad and tragic stories of people who are living with and caring for those living with lung conditions. As I said before, respiratory is often under prioritized and people don't necessarily perceive it as important and as life threatening as it is. And that's something that we all together can make sure is not the case going forwards. Talking about going forwards, my next slide shows you the 3 different shifts that the government has laid out for reforming the NHS. So the NHS 10-year plan, the new 10-year plan, is going to be published hopefully in the spring of this year, 2025. And what the government has said about that is that they're looking to reform the NHS in 3 different ways. So shifting from a sickness to prevention, from hospital to community care, and from analog to digital. And I think it's really important that that this is the case. One, because that reform is absolutely needed. I don't think anyone in this room would disagree that change is needed at the moment. But also it's really important for asthma care. We need to be preventing people not only from getting asthma in the first place, but also, preventing them from exacerbating. And that's really where these guidelines come in. And by delivering that proactive basic care for these patients, then we can prevent them from ending up in hospital. We can care for them in the community. We can prevent them from getting more sick. And, there are options where a digital health system is not only helpful system-wide in terms of sort of joining up care between primary and secondary, but also for patients to be able to use their NHS app properly and access a GP when they need it, or access advice online when they are able to care for themselves. So yeah, that is sort of what is hopefully going to be happening with the new 10-year plan, and what we can all keep in mind when we're thinking about how to actually implement these new asthma guidelines going forward. I think, Julie, that might be my final slide.
Thank you so much. Thank you, Laura. And what an insight into the wonderful work that Asthma+Lung UK are doing, and also those powerful testimonies from the patients. It's really important that we continue to engage with organisations like Asthma+Lung UK, and as Laura said, they have resources for both the patients and for people like myself who are clinician on the front line. So thank you, Laura. Talking about the front line, I think I'd like to go on now, having listened to Laura, to see what it's like and how the evidence is driving these changes for the changes within the BTS NICE sign guidelines. We're still living with the legacy of the NRAD report. This was published on World Asthma Day in 2014, over a decade ago. It attracted a lot of media attention in the UK and elsewhere across the world. And there were some key findings, and I just want to draw your attention to some of the key findings. That even now, as many times as I've read this report, I still find disturbing. Triggers were not documented in approximately 50% of patients who had died. And as we know, the NRAD report was a forensic examination of nearly 200 people who had died. And during their final attack, 45% of people died before help. There was no evidence of a review in the last year for these patients who had died. There was underprescribing of inhaled corticosteroids. And sadly, implementation of the guidelines could have avoided 46% of deaths. And at least 5 patients with asthma were on a long-acting beta agonist as a monotherapy. and only 23% had a personal asthma action plan. And that is the driver. That is what's enabling the patient to understand what to do and when. 39% had been prescribed more than 12 short-acting beta agonists, and 4% had been prescribed 50 short-acting beta agonists in the year before they died. So you can see against this backdrop that a change is required. So let's look at the evidence then. Data from across the SABA in use asthma Sabina-3 global program demonstrates SABA reliever overuse is a global issue in asthma management. And we have just seen that, haven't we, from the key findings from the NRAT review. And the Sabina-3 findings demonstrated that 38% of patients in 24 countries across 5 continents are overprescribed short-acting beta agonists. And the authors recognise that drivers for SABA prescribing may differ by country, but SABA overprescription results in an unnecessary burden of poor asthma symptom control and severe asthma exacerbations with those associated risks. And the findings confirm the association between SABA prescriptions and poor asthma outcomes, and there was growing evidence that SABA overuse in asthma needs to be addressed if further reduction in asthma morbidity and mortality are to be achieved. And there is an association between SABA prescription and possession and severe exacerbations and asthma deaths. And this was reported in the Sabina-1, which was a UK study, and the Sabina-2, which was a Sweden and Italian study. So let's look at the patient's perspective then. Perhaps complex medication regimes patients forget, either intentionally or unintentionally. There's complacency about their asthma. We hear patients stating, I'm always like this is normal for me. I'm sure everyone in this room has heard that at some point. The inappropriate expectations of medication. I thought the blue inhaler was making my asthma better. And of course, we have to be cognizant of cultural and religious reasons. In some populations, the use of inhaler is seen as improper or impolite, and oral drugs may be favoured. So let's have a look at the summary then. We now have the new asthma guidelines. The BTS, NICE and SIGN have all come together and provided an evidence-based guideline which fundamentally changes how we diagnose and manage patients with asthma. More than a decade on, we are still living with the legacy of the NRAD confidential inquiry and the key findings in this report which demonstrated the areas for improvement which we have just looked at. And we've also heard from Laura and the Asthma+Lung UK, a mission for lung health. The government issued a rallying cry to the nation to help fix the NHS. The Health Secretary, Wes Streeting, calls on the entire nation to shape the government's plans to overhaul the NHS. And Laura has explained how public engagement will help shape the government's 10-year healthcare plan, which will be published in spring of this year and will be underlined by 3 big shifts in healthcare, which Laura introduced us to. We all as healthcare professionals need to be cognizant of the patient's perspective. The paradigm shift from a blue inhaler to a combination inhaler. We must validate their concerns about giving up their blue inhaler. This is achieved by exploring the patient's eyes, their ideas, their concerns and expectations. And we must also be cognizant of our colleagues and their own health beliefs and perspective, moving away from familiar prescribing decisions. This quote, I think, might help us. If you always do what you've always done, you'll always get what you've always got. It's now time for change. So introducing a flexible approach to delivering person-centered care in asthma. So where is the evidence then for this change? We now have a consistent approach, providing consistent approach. The BTS NICE Sign 2024 asthma guideline is part of a new asthma pathway. The UK pathway supports health professionals in making accurate diagnoses, promoting good practice, and providing effective treatment to control the condition and prevent acute asthma attacks. It also signposts to other relevant guidance for easy reference. The new pathway includes guidance on areas that fall outside the scope of this collaborative guideline, the BTS NICE Sign 2024 Asthma Management Guideline. This is a new collaborative guideline developed by the three organisations. So person-centeredness, let's walk in the footsteps of these people. The person perspective to provide evidence-based care and improve outcomes. Effective patient engagement. We've talked about ICE, ideas, concerns and expectations, to mitigate potential challenges with this transition. And supporting prescribing changes from the clinical perspective, the clinician's perspective. And the essential asthma toolbox, selecting the right inhaler for the right patients at the right time for the right reason. Evidence directs this change in practice, and we're going to examine some of that evidence. So key changes for implementation. The guideline reminds us to treat people immediately if they're acutely unwell or highly symptomatic at presentation, and then perform the objective tests that might help support a diagnosis. It's important that we adopt this sequential approach, so measuring blood eosinophil count or FeNO levels, either an eosinophil count or a FeNO measurement, but both need care and interpretation. The FeNO level is a proxy measure of airway inflammation. If asthma is not confirmed by eosinophil count or a FeNO level, measure the bronchodilator reversibility with spirometry. And a change in absolute values of FEV1 is the percent change compared with the person's predicted FEV1, and a change of 10% or more is abnormal. The traditional means is percentage of baseline FEV1 increased, such as reversibility demonstrated by 12% or more in adults and children, and in adults the change should also be 200 mils or more. If the tests are not available or there is a significant delay in obtaining them, the guidelines confirm it would be reasonable to use a peak flow variability as a substitute rule-in test. And bronchial challenge test is a test to measure airway responsiveness, the bronchial responsiveness. It is performed by giving small incremental doses of a bronchoconstrictor, most commonly methacholine, and measuring the FEV1 after each dose until it falls by a predetermined amount, usually 20% from baseline. In the next webinar, we will talk in more detail about the objective tools and their nuances. So looking at the sequential approach for implementing objective tools in the 5 to 16-year-old. I'd like to draw your attention to skin prick testing, a test that measures the allergic response of an individual to certain specific allergens when a very small amount of the specific allergen is introduced into the skin, usually the inner forearm. For eosinophil counts and IgE levels, a raised measurement suggesting asthma should be regarded as one above the upper end of your local range. So time for change. We'll explore in more detail in a forthcoming webinar the detail behind the prescribing choices. However, as an introduction, medicines for the initial management of newly diagnosed asthma in people aged 12 and over. People aged 12 and over with newly diagnosed asthma were previously treated with either a SABA alone or a regular ICS plus SABA as needed. The new recommendations represent a significant change in practice. The use of combination inhalers is more expensive than SABA alone, but cheaper than regular ICS plus SABA as needed, and offer a low-dose ICS formoterol combination inhaler as needed, referred to as the air therapy. to people aged 12 plus with newly diagnosed asthma, and if highly symptomatic, for example, regular nocturnal waking or severe exacerbations, start treatment with a low-dose MART. So medicines for initiation management in children aged 5 to 11. Evidence for children aged 5 to 11 showed that regular pediatric low-dose ICS plus SABA as needed was superior to SABA alone, particularly in reducing exacerbations. There was no evidence for ICS formoterol combination inhalers used as needed in this particular age group. The guidelines therefore recommended regular pediatric low-dose ICS as the preferred treatment option for children aged 5 to 11. But in view of the evidence supporting the use of ICS-LABA as needed combination inhalers in adults, the committee made a research recommendation to test the benefits of this combination in children. So watch this space. So now let's look at the science behind this driver for change. How do these treatments work? Combination of ICS and a long-acting beta agonist. And in this case, it will be formoterol. In this study, formoterol was referred to as fast-acting. We will see more of this later. So the AIR evidence for mild asthma. A Cochrane meta-analysis of available trial data examined 6 studies from which 9,657 participants contribute to the meta-analysis. They all used dry powder budesonide and formoterol, the fast-acting, long-acting beta agonist, as the combination inhaler. And the author's conclusion, the fast-acting beta agonist, ICS as required, is clinically effective in adults and adolescents with mild asthma. It reduced exacerbations, it reduced hospital admissions or unscheduled healthcare visits, it reduced exposure to oral steroids, and as required is as effective as regular ICS. So that starts with the evidence behind. Let's also look at the sigma-1 and the sigma-2. The sigma Symbicort given as needed in mild asthma studies evaluated the efficacy and safety of PRN budesonide and formoterol in patients whose asthma was uncontrolled, either on PRN SABA, that was subgroup 1, or controlled on ICS, or leukotriene receptor antagonist, that was subgroup 2. And these findings suggest that for patients with mild asthma currently receiving SABA alone, PRN low-dose ICS formoterol, i.e. AIR, should be preferred over maintenance ICS as the initial controller treatment. And for patients whose asthma is controlled on maintenance low-dose ICS, PRN budesonide formoterol is an alternative to maintenance ICS without the need for daily treatment. And both of these options are safer than switching to SABA-only treatment. So you can see across these arms the different outcomes and the median total dose of ICS load according to the pre-study treatment in both the sigma-1 and sigma-2 trials. So let's look at the evidence for the MART approach then. We have Kate's Kana combination formoterol and budesonide as MART therapy versus current best practice, and that's including inhaled steroid for chronic asthma in adults and children. The maintenance and reliever approach, the MART approach with ICS formoterol, reduces the risk of severe exacerbations by 17% compared with usual care, by 32% compared with the same dose of ICS and LABA, and by 23% compared with a higher dose of ICS and LABA. So what about high-dose MART? Beasley et al. In 2024 acknowledged the available evidence suggests that medium-dose ICS formoterol MART has a superior efficacy, safety profile than high-dose ICS LABA plus SABA as their reliever. So more and more evidence is coming forward. And this is a quote from Beasley et al. The level 1 scientific evidence of the greater efficacy and safety of ICS formoterol versus SABA reliever therapy across the range of asthma severity allows grade A recommendations to be made for its use as the preferred reliever therapy in adults and adolescents. So this was a study done by Rabb et al. In 2006, published in The Lancet, and it conducted a 12-month double-blind parallel group study in 3,394 patients aged 12 and over across 20 different countries. And these were patients who were using inhaled steroids at study entry and symptomatic on budesonide formoterol in 2 different doses, one inhalation twice daily. They were then randomized and assigned either budesonide formoterol maintenance therapy plus one of 3 alternatives as needed medication, either terbutaline or formoterol or combined budesonide formoterol in different doses. And you can see the primary outcome was time to first severe exacerbation, defined as an event resulting in hospitalization, emergency room treatment, or both, or the need for oral steroids for 3 or more days. You can see the results show that maintenance plus as needed budesonide formoterol, otherwise known as MART, reduced the risk of severe exacerbations and events resulting in emergency room visits or hospitalizations compared with maintenance budesonide plus either formoterol or terbutaline as needed. The combination arm is the red arm. You can see the number of patients with severe exacerbation was lower in the combination arm versus the SABA or formoterol. So Gina, back in 2019, air is not a new idea. Evidence of the harmful effects of SABA use, including risk of death, has been available for decades. Spitzer et al. In 1992 examined a cohort of 12,301 patients prescribed asthma medications right down to 1978 and 1987. It goes back decades. An increased risk of death or near death from asthma was associated with the regular use of inhaled beta agonists. And the 2019 asthma recommendations changed decades of asthma care. Gina made groundbreaking recommendations in 2019 for the use of ICS formoterol as needed for symptoms either alone as part of the AIR or MART in adolescents and adults with asthma. So let's look at the potential challenges for implementing the new guidelines. Consider pediatric low-dose MART for children with asthma that is not controlled on pediatric low-dose ICS plus SABA as needed, as long as they are assessed to have the ability to manage a MART regime. So remember, in this group, the evidence isn't as robust as in 12 plus. However, it is considered an option. So strategies to support patients that may resist air and MART, a reluctance to give up a SABA inhaler. We need to be familiar and listen to what these patients' concerns are. Patients' perception of this new approach. For decades, there have been an emphasis on the regular ICS use, and now we're going to be changing that. There's professional considerations when prescribers may need to consider an off-label use for the MART regime in children or young adults 5 to 11. And there's concerns among some clinicians about access to phenotesting and spirometry services. So let's look at the strategies to support a patient-centered, flexible approach. More evidence. Evidence to support patients' decision-making and choice for the onset of action of their new reliever if reluctant to change from SABA to AIR is promoted in a moment. I will show you some evidence that I think will help you to engage and have those conversations with the patients. Evidence of the efficacy of this approach will drive its implementation. So let's have a look at the summary of product characteristics. Salbutamol is a selective beta-adreno agonist. At therapeutic doses, it acts on the beta-2 adrenoreceptors of bronchial muscle, providing short-acting, i.e. 4 to 6 hours bronchodilation with a fast onset within 5 minutes in reversible airway obstruction. This is from the summary of product characteristics. Now let me read formoterol. Formoterol is a potent selective beta-2 adrenic stimulant. It exerts a bronchodilator effects in patients with reversible airways obstruction. The effects set in rapidly within 1 to 3 minutes and is still significant 12 hours after inhalation. One professor spoke to me recently and he described it as an upgrade. So this is the evidence to show formoterol's onset of bronchodilation is similar to salbutamol after 3 minutes. This graph illustrates the onset of action for formoterol versus salbutamol. And for those patients reluctant to move away from their SABA therapy, this slide highlights a powerful message. So strategies to support a patient-centered, flexible approach. Essential for understanding a patient's viewpoint, and it's a cornerstone of patient-centered communication, and ICE helps ideas, concerns, and expectation. It helps us establish the patient's health beliefs, it helps us to reach a shared understanding, and it enables us to use open-ended questions. So many patients will have come from a traditional SABA-based approach, which is inherently different, and thereby creates the potential for uncertainty. This requires the health professional having a structure to the implementation approach they use in clinical practice. It's about validating the patient's concerns, their ideas, concerns, and expectations, and capturing the patient's perspective. It's about sharing confidence from clinicians about the effectiveness of air and MART, which we've just looked at. And it's about signposting for patients such as Asthma+Lung UK. So this is an example of the Air Asthma Action Plan, and it provides what to do in an asthma attack. So sit up straight, and this is in the red section. Try to keep calm. Take 1 puff of your air inhaler every 1 to 3 minutes, up to 6 puffs. If you feel worse at any point or you don't feel better after 6 puffs, call 999 for an ambulance. If the ambulance has not arrived after 10 minutes and your symptoms are not improving, repeat step 2. And if your symptoms are no better after repeating step 2 and the ambulance has still not arrived, contact 999 again immediately. And if you do not have air inhaler, you call 999 and let them know. So it's very, very clear. There's your worsening statement and safety netting. Masterclass 2. Next time we will discuss diagnosis and assessment. We will take the questions and provide them as a fact sheet as required. Thank you so much for listening, and I hope this has helped you understand the positioning of air and MART, and we look forward to joining you on Masterclass 2. Thank you. Bye-bye.